Hello guys, very good morning. Welcome back. So today we are going to be in the third session of IBQs. So we have discussed that we will be having 10
Hello guys,
session of
very good.
IBQs in total. So first one was on the Unacademy app, second and third was on YouTube channel. If you have missed the second one, please go to the YouTube uh, channel of Unacademy. Under that you'll be having my playlist individually so that you can go and have a look at that, right? So today we'll be discussing the third IBQ session. Okay, so what we'll be doing here is in the 10 IBQ sections I am trying to cover almost everything which is required from the general pathology perspective and also the systemic pathology perspective, so that together we can learn a little bit more and we'll be able to apply as well. Fine. So the sessions are basically a kind of an adjuvant to people who have already prepared. I would say that these sessions will not be the primary source for you to learn. The concepts building will be erratic here, a few of them in different chapters, right? So I would say that the best way to learn concepts, if you're in a starting phase of your NEET PG or next prep, let's say attend a complete course, right? So you can download the Unacademy app, and there are many special classes. You can be a part of it, and there are a few focused NEET PG focused classes as well, and a few FMG focused classes also. If you want, you can get a use them as well. Just a second, give me a second. Okay. Yeah, I'm back, sorry. Okay, and the second Unacademy NEET PG Combat is on cards, and you will have them by 19th of December, 5 p.m. The same thing goes here. You can attend it everywhere. Questions have been curated by us. You will have an explanation by us as well. And you can have a real-time All India rank, so that there's no problem that I scored better and you didn't score better. And you'll have scholarships up to 50 ranks, up to 50%, and up to 200 ranks 25%. You can use any code to enroll to the NEET PG Combat. If you don't have one, use Patho Cups. Fine. So that's the starting of today. So we'll start with our MCQs. Okay. So again, the MCQs goes the same. I want you to read the MCQ, look at the image, come to a conclusion with the help of the MCQ history, and use the options. And image is supplementary for any IBQ sessions, right? So just go and have a look at this question, and then let's see what to go with it. Okay, we give 5 seconds. I want everyone to comment the answer here. It's going to be a practice session for all of us, so it's fine if you make mistakes. Okay, I'll mute it for 30 seconds and I'll start discussing soon. Okay, I hope that should have been enough time for you to look at the question. So we'll read the question and then we'll come to a conclusion, a preliminary conclusion. Okay, Abhi has started with B. Let's have a look at B. Fine. A 64-year-old person presents with history of weight loss and progressive yellowing of skin and sclera. That's icterus or jaundice. Fine. Ultrasonogram shows liver with multiple lesions. A FNAC is performed, and the image of the FNAC, there's a liver FNAC which is given here, right? There are a few points I want you to talk about liver FNAC that will follow it soon. Fine. The smear discloses numerous round cells, poorly defined cytoplasm, eccentric nuclei, and prominent nuclei. That's fine. That will be the case for most of the malignancies, right? So what kind of dragged you to hepatocellular carcinoma? See, I'm sure that you won't think of an hepatic adenoma. It's poorly defined cytoplasm, prominent nuclei, everything going in terms of a malignancy, right? Again, these three are malignancy, and what do I choose will be the answer first. First, when you look at the history, the patient is having multiple liver lesion. Whenever any lesion in any part of any organ, if it's multiple, you think of a primary or metastasis. This is a very important clue for me here. When I have multiple lesions, what do you think of? We generally think of metastatic deposit, right? It's not only in the liver, in the lung, in the brain, anywhere you see multiple lesions, metastasis is more on cards compared to the primary, right? So this again kind of a remote possibility for me now. A and B is kind of ruled out. I have option C and option D, both are metastasis. So what do I choose with them? Option C is metastatic adenocarcinoma. See, if I have to have an adenocarcinoma, and Amrish went for option C. So if you have to have an adenocarcinoma, what do you see in microscopy? For any adenocarcinoma, I need a structure in microscopy. What is that? We should have either glands or mucin, right? Because mucin secreting adenocarcinoma are more common. So to have that microscopy, I should have a well-formed gland, or I should have cells with intracellular mucin. I'm not having anything of that sort. If I have a cell with a completely clear vacuole, this I'll call it an intracellular mucin. I don't have mucin, neither I have glands here, right? So, but on the other hand, if you look at the image carefully, there are maybe 5-10 cells there. I just zoom a little bit. I'm sure you must have seen this, or you might have missed this in the first go. Look at this image alone. If you look at this image alone, in the cytoplasm, do you see anything? Is there any peculiarity in the cytoplasm? If I have to give you a hint, is there any pigment in the cytoplasm? There is a pigment, right? Can you see a blackish color pigment? Yeah. So this here is my clue here, right? I do have a pigment in the cytoplasm. When I have pigments in cytoplasm, there are very few neoplasms which will have pigment. Of the options given here, obviously melanoma will have pigment, right? So it's in metastatic melanomas FNAC. So FNAC of any melanoma, see, amelanotic melanoma will not be given for undergraduate. It's very difficult to pick it up. So when I have melanin in the image, the only option here which fits is going to be metastatic melanoma, fine? Okay, it's completely fine. You make a mistake, doesn't matter at all. No one is who's going to watch this video is going to judge you, and even if they judge you, they are not worth it. Don't worry about it, fine? Neither me, I also will not judge you, fine? It's fine. It's an exercise for us. You make mistake here in the live chat, you will not forget. That's the only goal. Take home message from here, fine? So the diagnosis here is metastatic melanoma. So as I said that, I want to talk something about liver FNAC, right? See, when you are an intern or a PG, whenever you're going to evaluate a patient, there might be an instance that I need a liver FNAC to be done, or a liver, not only liver, any invasive procedure. Let's take, when I say invasive procedure, I can include your liver FNACs, kidney biopsies is invasive, ovarian biopsy is invasive, any intraperitoneal biopsies are invasive, right? Or an intraperitoneal ones, or I can say a pleural pericardial tap. See, that's also invasive, right? So whenever I'm going to do any invasive procedure, I want you to look at one thing, which is prothrombin time. Please keep this in mind. This is very essential. Before doing liver FNAC, prothrombin time should be normal. Especially in kids, this is an absolute necessity, not just in kids, everyone. If prothrombin time is abnormal, let's say it's elevated for a patient with a metastatic melanoma, when there's a metastatic melanoma, there is a possibility that liver could be damaged, right? So there's a possibility that liver could have failed, and liver produces almost every clotting factor. If prothrombin time is elevated, and in spite of that, I do a liver FNAC or any invasive procedure, will that be a hemorrhage? There will be an hemorrhage, which I cannot control, right? So this is a very important prerequisite. When you go as an intern, when you're assisting any procedure, make sure prothrombin time is normal. Same goes whenever you are in any part of your life, right? So investigation of any intra-abdominal, intraperitoneal closed cavity, I have to do a prothrombin time, and it should be normal, fine? That's it. One take-home message for you from this question, okay? Okay, we'll go to the next question. We're going to do the same thing. Read the question very carefully. There'll be subtle hints in the question, and also image will have a tiny hint, and then let's easily come to a conclusion, okay? I'll mute it for 30 seconds, and I want you to comment the answer. Okay, comment on the answer. Okay, Bindu and Abhi has gone with A. Anyone else wants to add up? Okay, Amresh is also for A. Fine, great. See, this is the best part about an exam and learning, right? So we had a slight mistake in the previous question, and then we kind of learned from that, and we're going to apply in the next question, right? So when you look at this question, it's a 55-year-old person with a 4-month history of increase in abdomen girth and pelvic discomfort. So I'm thinking about some adnexal lesion, right? Must be in the adnexa, either ovary or maybe some uterine lesion as well, fine? Okay. The blood test shows CA125 positive. See, this is kind of comfort for me. They don't give the value. When they say positive, I'm going to incline towards malignancy since I don't have a value here, right? An ascitic tap has numerous papillary fronts and has few epithelial cells. And the epithelial cell microscopy is given here. See, these are my epithelial cell. The question gives you its papillary fronts, though I don't see the papillary fronts here. I am seeing just the epithelial cells here. But I want you to observe on one important finding in these epithelial cells. What are these? What are these structures? They are clear structures inside my cytoplasm of the epithelial cell. Can I call all these structures as mucin? It does look like a mucin, right? Sorry? It does look like a mucin inside the cytoplasm, and these are just adenocarcinoma cells. They are pleomorphic for sure. I do have one nucleus very tiny. I have one nucleus like cleaved and bigger one, right? Pleomorphic cell with intracellular mucin. The image alone is enough for me to call it adenocarcinoma. Again, unlikely to be melanoma for the simple reason I am not having pigment here. Mesothelioma is a very, very rare finding, and one thing for me for mesothelioma is CA125 is not going to be altered in mesothelioma. Neuroblastoma also CA125 is not going to be altered, right? So the only possibility based on my history as well as here is my adenocarcinoma of ovary, right? When I take an ovarian lesion, we divide ovary lesion into many groups, right? This INICET also had a very basic question of what category of tumor it was, right? We divide them into epithelial lesion, we divide them into germ cell lesion, we divide them into sex cord stromal lesion, and we have the others, right? And we have the metastasis, right? What are the epithelial lesion you know in general of ovary? All of you got the correct answer. There's a great sign for us to learn together. Epithelial lesions of ovary, we have mucinous, serous, endometrioid, clear cell. That was a question which came in INICET, and your Brenner, right? We have a few others as well. We can have mucinous lesions, we have serous. I'm just going to concentrate on epithelial alone this time. We have your clear cell, we have endometrioid, we have Brenner, and we have to mixed type as well. Fine. So we have these epithelial types of ovarian lesion. These epithelial types are not just for your malignancy. I do have mucinous cyst adenoma, borderline cyst adenoma, and mucinous cyst adenocarcinoma. Same for serous, benign, borderline, malignant, clear cell also, endometrioid also, Brenner also. All these three will have. It's not just benign or malignant. I do have categorization of benign, borderline, and malignant. Okay, it's always like this. Always you're going to categorize like this. Fine. I'm just going to ask you one more leading question. CA125, is it always diagnostic of a cancer? Like let's say if CA125 is elevated 100 units, just for example, can it be elevated in a mucinous cyst adenoma? Possible, not possible? Or a serous or whatever it is, cyst adenoma in a benign lesion, is it possible? Definitely, right? A CA125 can also be elevated in my benign lesions also. That's a finding seen. It can be elevated in your endometriosis. It will be elevated in your PID, right? There are many places where CA125 can be elevated, right? Because I want you to come to an approach, because this is what the consultants in real life do, right? So I'm having a CA125 which can be elevated, and let's take a mucinous neoplasm. You must have read in your obstetrics as well. Can mucinous neoplasm grow to 10-15 centimeter? That's one of the lesions which can grow very huge size, right? I do have mucinous adenomas, the benign tumors, which can grow for 10, 15, 20 centimeters in size. A radiologist is going to look at them. 10-20 centimeter size, will they be septate? They will be loculated as well, right? I have a huge lesion which can be loculated, and it's in a, let's say, 45-year-old group. If you have all these pointers, a radiologist and clinically with elevated CA125, I will think of a cancer or a benign lesion. Elderly person, a very big lesion, lots of septations with elevated CA125. My primary possibility is going to be malignancy, right? So, but there is a possibility of benign lesion also there, right? So how do you rule it out? That's very important for us. When I have the scenario like this, the consultants opt for frozen section. There are questions coming on frozen section continuously on every exam, be it NEET or INACET or FMGE. You have to know about frozen section. The advantage of frozen section intraoperative is I can tell you whether it's benign, borderline or malignant. Based on that, the surgery is going to be changing, right? If it's just a benign lesion, just a removal of ovary should be more than enough. Borderline malignant, you have to take the adnexal structure along with the uterus also, right? Frozen is very, very important for it and helpful for an ovarian lesion. Okay, that's one take home message here. We're just going to have one take home message for every question if possible. Okay, next question. Again, I'll mute the thing for 30 seconds. Read the question carefully, read all the options, and then come to a diagnosis. Okay, comment on the answer. It's fine if you're wrong, but I just wanted to comment on the answer. Okay, Abhi went with D. Amresh went with D. Quite a few of you are going with D. Okay, let's read through the question and let's see how to come to a correct answer. Fine, great, great. One happy thing for me here is, since we had two questions of a malignancy, you didn't opt for adenocarcinoma. That's a very good sign for me. I think what went you to think about an infectious process here is my first line, right? A 36-year-old HIV positive patient with dry cough, fatigue, and low grade fever. Physical examination shows pallor and respiratory distress. X-ray is also very, very important here. It shows a bilateral interstitial infiltrate and diffuse. It's like your reticulonodular pattern, right? If your radiologist must be the best person to talk about reticulonodular infiltrates, and I'm sure you must have known that as well, right? The bronchoalveolar lavage shows lots of foamy alveolar cast. That's more important. This foamy nature is very, very important for this diagnosis. This is the tiny, tiny microcyst, right? If you remember your pneumocystis, this is a classical case of a pneumocystis carinii sputum finding. When you remember clinical investigation or symptoms of a pneumocystis, a patient with a pneumocystis, what color sputum or what quality of sputum will they have? You must have read them. Like Klebsiella will have a brown color sputum, normal, typical pneumonia, a muddy brown sputum, your red currant jelly sputum for Klebsiella. Like that is a very, very characteristic sputum for pneumocystis. What is that? Pneumocystis always will have a frothy discharge. The frothy discharge is what actually I'm seeing in my microscopy as well, because pneumocystis attacks my alveoli per se. From the alveoli, there's going to be increase in secretions. Along with the air, it comes bubbled out. Those bubbled out air-filled mucus secretion are my cyst here, cystic spaces in my sputum microscopy. Same one is going to cause my frothy discharge as well. Fine. So just a pneumocystis carinii pneumonia. With the help of history also I can kind of delineate pneumocystis pneumonia. Otherwise with the help of microscopy also I'll be able to answer it. Fine. One more thing. In pneumocystis pneumonia, I'm sure you must have heard about one named finding as well. What name finding do you know about pneumocystis pneumonia? Carinii or Girovesi? You had name finding collagen. I'm sure you must have heard this. Ping pong ball appearance. Right? Or in cup and saucer appearance. See, this is also very characteristic for pneumocystis carinii and Girovesi. A cup and saucer on ping pong ball appearance, right? So what will happen is this lesion kind of looks like this, the organism, with the spore in the center. That kind of looks like a ping pong ball. Ping pong is your table tennis ball, the bat with the ball appearance, or your cup and saucer appearance from the top view. Fine. So this is also a very characteristic finding for pneumocystis carinii Girovesi. If you don't have this froth, you look for this finding in your microscopy. And this finding is better appreciated on one specific stain. Okay, again an open question to everyone. What are the stains I do in microscopy for a fungal infection? There are two stains which are done for fungal infection. What are they? The first one is PAS, right? Perfect. I do PAS and we do GMS stain, right? So PAS and GMS stains are the one which is done for fungal infections. That's very classically used for fungal infection. And in GMS stain, the Gomori methenamine silver stain is where you can appreciate the ping pong ball appearance. Fine. This can be useful for any fungus, regardless of whatever it is. Okay. Perfect. Great. Fine. We'll go to the next question. Again, I wanted to read the question very carefully, look at the options, and give the answer. We'll go for mute in 30 seconds, and then we'll start again. Okay, answers. Okay, Amrish, Abhi started the thing with option C. Anyone else wants to join? It's a very classical history. C, pseudo rosettes and C, great, fine. I'll read through the question. It's a 50-year-old person with 5-month history of severe headache. A vital sign and CBC is normal. The imaging study shows a mass in the fourth ventricle causing hydrocephalus. The result of a CT cardiac biopsy is as given below. Which of the following is the patient's diagnostic condition here, right? So all of you went with option C. What you see in option C? What is the exact finding? What you're looking in option C? Because I want to take Dipashri's input as well as what you guys are thinking about it. Did you guys think this as palisading necrosis? Was that the reason you went for option C? Because what we see in option C is the palisading necrosis, pseudo palisading necrosis, right? So option C, glioblastoma, the finding seen here is pseudo palisading necrosis, right? That's what we see in option C, the glioblastoma. This exactly looks like that. But like what Dipashri said, that she said it's pseudo rosette. Am I right in saying that the center of this lesion, just concentrate in the center of this lesion, are you seeing a blood vessel? Perfect, Amrish. Are you seeing a blood vessel in the center of this lesion? Yes or no? You are seeing a blood vessel, right? If you want, I'll zoom it a little bit. Are you seeing a blood vessel? Definitely I'm seeing a blood vessel. When I'm seeing a blood vessel in the center of a lesion, can I call this pseudo palisading necrosis, or is it a pseudo rosette? This is a pseudo rosette, not a pseudo palisading necrosis, right? This is just a perivascular pseudo rosette. Perfect. So now can I rephrase the question? It's a perivascular pseudo rosette, but it's a perivascular pseudo rosette. When you look at the options, tell me which of the 4 options will have pseudo rosettes. This is a deception question. I want you to take this as a learning thing, and I don't want you to make any more mistakes in the same arena in future, fine? If it's a pseudo rosette, my diagnosis is going to be ependymoma, right? Small round blue cell tumors have pseudo rosettes. Glioblastoma will not have a pseudo rosette. Glioblastoma will have pseudo palisading necrosis. I'm sure why you guys went for pseudo palisading necrosis and option C, because you have seen similar images multiple times in many sessions by many educators. Thing is, I am looking only at the image as a major flaw for most of us. When you are given a question, please read the question. There will be subtle hints in the question. Those are more important for me than the images. Please don't look at any image for any subject in any question. Let's read the question again. It's a mass in the fourth ventricle and hydrocephalus. Will glioblastoma happen in the fourth ventricle or in the cerebral cortex? It's a glioblastoma, option C, which most of you guys said, is a finding seen in the cerebral cortex, right? Not in the fourth ventricle. It's an intraventricular mass. Will ependymoma be intraventricular? Ependymal cells line the ventricle? Yes, ependymoma is intraventricular, right? So I have a very classical finding here. It's an intraventricular mass causing hydrocephalus. The answer again clinically is also an ependymoma. Microscopy is also an ependymoma. Microscopy, it looked like pseudopalisading necrosis. So how do I differentiate these both? Look at the microscope finding here. See, I have 2 images here, 1 and 2. The first one, when you look at this, can I say the center of this is completely pink in color and it's necrotic? Yes, it's necrotic, right? So this is necrosis. I don't have a rosette formation here. And one of the most important characteristic finding in glioblastomas, you must have read that it's in serpiginous necrosis. It's not just pseudopalisading, it's serpiginous and pseudopalisading. Serpiginous means like a snake, it's just irregular, that's all, right? It's definitely irregular. It's not regular like the pseudorosette, right? It's in serpiginous necrosis. So every word is important for me to come to the right answer. When you look at this image is what was there in the question. It's a blood vessel in the center, surrounding by cells. This is nothing but a perivascular pseudorosette. Perivascular pseudorosette is a non-specific finding. It can be seen in many tumors, including ependymoma. It can be seen in Ewing's. It can be seen in medulloblastoma, neuroblastoma, many tumors. Fine. Of the options given here, it's going to be ependymoma. Okay, great. Fine. So don't make mistakes just by looking at the picture alone. Please take in consideration the history, the age, the presenting findings, everything, and then come to an answer. Okay, we'll go to the next question. Okay. Read the question carefully, give your answer, then we'll have a quick discussion based on that. Okay, I think that's enough time to read the question. Tell me answer. Whatever it may be, it need not be right always. It's just a learning exercise for us. What do you think will be the answer? Great. Abhi has started with C. Anyone else wants to pitch in? Great, Hina, Akanksha. Good. It's fine. Do comment. What is going to make us better is making mistakes, right? Almost everyone went for option C. Fine. Let's read the question. It's a 27-year-old person coming for routine checkup, and she's been doing the routine checkup of pap smear right from 21 years, married, and sexually inconsistent use of condoms. But the pap smear shows an ascus. Ascus is the initial abnormality, right? It's normal. Ascus is just few atypical cells. Then after ascus, we have a categorization called as L cell, low-grade squamous intraepithelial lesions, and we have H cell, high-grade squamous intraepithelial lesions, right? As of date, the recent WHO said that please don't report CAN 1, 2 and 3. That should be avoided. L cell is CAN 1. I want a dual scoring system only because it removes many probable mistakes. CAN 2 and 3 are H cell, right? As of now, even for biopsies, I report only L cell and H cell. That's a recent update by WHO 2020. I should not report CAN 1, 2 and 3. The gynecologist should change the protocols based on L cell and H cell only. Fine. So when I find any tiny atypical cells in the FNAC, in the pap smear, I have to perform a DNA test, right? Previously, what we are doing is we are keeping the patient on follow-up. With the availability of an HPV DNA, it's more comfortable for me. I am diagnosing it early, that's all. Let's assume the patient is having an HPV DNA done, and it shows the high risk phenotypes, HPV 16 and 18 positive. Then it becomes very clinically relevant for me to go ahead with the treatment. I will not just wait and watch there, right? If it's only 6 and 11, low grade phenotype, benign phenotype, I'm not going to do anything, maybe wait and watch. So the decision making is based on the HPV phenotype and not just based on microscopy, right? And the test used for HPV DNA testing is hybrid capture. Okay, you might be asked the name. I'll tell you the principle also. It's called as a hybrid capture technique. This is the principle of hybrid capture, whatever you're seeing in the image. So it tests for all these. All of them you're seeing there, all of them are high risk phenotypes. There are 13 high risk phenotypes tested in my hybrid capture in a single test. I don't want to do 13 times. Though my predominant things are 16 and 18, I'm checking for whatever is available. That's more than enough for me, right? Instead of doing one test for everything, I'm hybrid. Hybrid is I'm mixing many things and doing in a single test. So what do I do in hybrid capture is, I'm going to take the patient specimen. If this patient specimen has HPV DNA, only then it's going to work, right? This is patient specimen. The same pap smear what we do, the few cells there is enough for me to take the nuclear material, right? So if the patient specimen has an HPV DNA, I'm going to make it single stranded, add an RNA probe. See, this is complementary. This is complementary to the high risk phenotypes. So that's what we do, right? So what I'm going to do is, this RNA probe is not only one. This RNA probe will be matching all the high risk phenotypes here, right? So let's say that this patient has HPV 35. So will the RNA probe bind to the HPV 35 of the DNA? It will. So whatever phenotype it may be, it will. Let's assume that the patient is having no HPV infection or has HPV 6 or 11. Will the RNA probe bind and will it form a hybrid? 6 or 11 in the patient or no HPV in the patient? Will the RNA probe bind? It will not bind, right? If it doesn't bind, my test is going to be completely negative. If the patient has any HPV DNA left, very tiny molecules also enough for me, this RNA probe will bind to it, I'll form a hybrid. So what do I do in a hybrid is, it's just a hybrid which we have wells, it's like an ELISA well but very tiny micro wells. To that I add antibodies and I give a color, which means if the color is present, this is the test kit called as hybrid capture kit. If the color is positive, I can say that the patient has even a tiny quantities of, or maybe abundant quantity of my high risk HPV DNA. HR is for high risk. Fine. It's a high risk HPV DNA. It need not. I cannot tell what type of DNA it is. I cannot tell it is 16 or 18. I can tell it's a high risk phenotype present. Fine. That's what we do in hybrid capture. It will not detect 6 and 11. So if hybrid capture is negative, I am not ruling out HPV. I am ruling out the high risk phenotypes are negative. The low risk one still can be there. Fine. Okay. That's a method to do HPV testing. It's routinely done. There are many places where pap smear is, without even knowing the report of pap smear, they incorporate HPV DNA testing together. There are few places where they go with HPV DNA first, then they go for pap smear, because this is more accurate, right? Because in future, if you're going to become a gynecologist, I want you to rely on more of HPV DNA than the pap smear reports. More sensitive, more specific, and a better management for us. Fine. Okay. For next question. Okay, read the question. It's a very, very simple one, and then let's go to the answer. I'll mute it for 30 seconds. I think that should have been enough for you. Start commenting. I want everyone to comment here. The question is simple. Which are the 4 options describes echinocytes? Right, that's very classically given in the question as well. Okay, 4. Okay, Bindu started with 4. It's echinocytes. Preetham is also for D. 4 again. D. Okay. Anyone wants to differ? It's fine if you're wrong. Okay, all of you are going for 4. Fine. So look at the RBC abnormalities, the RBC findings, then we'll come to the question. Fine. Okay. There are a few images here which might help us to clear the thing here. What are these cells called as? These are the very, very classical cells. I'm sure you'll know, right? You can even comment the first line. That's also first word. That's also enough. These are your classical target cells, right? The other name for target cells is podocytes. They're also called as podocytes. The reason for target cell is they are like a very loose cell membrane, right? The cell membrane is not so perfect, so it becomes a target. The cell membrane actually is like this. The cell is actually like this. It's like a bill. Codo means a bill. It looks like a bill, so it looks like that. Because of the hemoglobin alteration, the center part alone gets more hemoglobin. That's it. Fine. So if I see target cells, what are the conditions which comes to your mind? The places where we see target cells, the diseases. The first thing for me is TAL. I can see them in sickle cell anemia. I can see them in severe case of iron deficiency anemia, right? I can also see them in your, very rarely I can also see them in your liver disorder, right? So these are the places where I can see a target cell. And just a target, that's all. Okay. So we have a target cell here. We know how it looks. Same way we're going to look for every other cell and we can come to an answer easily. Fine. What is this? What cell is this? What are these? What are these? They are irregular. They are blunt. They are large, right? They are large projections. They are not uniform. They are not uniform projections. And they are irregular projections as well, right? What are these projections called as? Or these cells called as? Perfect. We call them acanthocytes. Again, whenever you see acanthocytes, see it's a normal cell. My cell's membrane, any cell's membrane is made of phospholipid bilayer. That's all right. My cell is going wavery like this. It's not regular. So can I say that the phospholipid bilayer here is abnormal? It is abnormal, right? That's the reason I'm having lots of waving cytoplasmic membrane. So if my phospholipid bilayer is abnormal, something is going to produce phospholipid is damaged. lipid production, metabolism happens in my liver disease. The first possibility of acanthocyte is liver disease. I'll show you Abi. We'll look at spur cell. This is the other name of this is spur cell, right? We'll look at both of them, burr and spur, fine. The second disease where I can see them is A beta lipoproteinemia. Okay. So in A beta lipoproteinemia, can I say that beta lipoprotein is defective? I am not able to absorb them. When my lipoprotein is not able to absorb, my phospholipid synthesis is going to be abnormal, so it becomes wavery like this, right? So these ones are irregular and blunt. If you've seen, I'll tell you a reason why it's called spur cell, because it'll be easy for me to remember and it'll lose confusion, fine. If you've seen cowboy movies, old Hollywood movies, the Once Upon a Time in Hollywood, the movie was there, right? So when you see the movies of a cowboy, generally the boots of a cowboy, the shoes of a cowboy will have a ring like this and irregular, non-uniform spikes. The reason for that ring is it will be used to hit the horses so they can move faster, right? So this is called as a spur. This is a cowboy spur. So this cell looks like a cowboy spur, so they call it a spur cell, right? So then other name for acanthocyte is spur cell. Fine, got it, Abhi? So it's both are one and the same. There's one more cell called as burr cell. We'll look at that soon, right? You look at this cell, this and burr cell, or an echinocyte. Our question was echinocyte, right? So now look at this image. The projections here are large or small? Large projections or small projections? They are small projections, right? There will be tiny little projections. Are these projections uniform or not? They are uniform throughout, right? They are regular, they are uniform. They are uniform and they are regular projections. I have a small projection and uniform and regular projection. I'm going to see them in echinocyte. I'm going to call them echinocyte, and the finding where I see echinocyte is and CKD. A chronic kidney disease is where we'll see echinocyte, right? So now we'll look back to the question. I think now it will be much more clear for me. When you look at the question, it's echinocyte. Most of you answered option D, right? Larger and more uniform. I won't have a larger projection for an echinocyte. Generally, it will be smaller and a more uniform projection, right? A smaller and a more uniform projection is diagnostic of an echinocyte. Option A is the correct answer, okay? We'll go next one. This is a simple one. What are these? This cell, your sickle, or we call them drepanocytes, right? Sickle cells, the other name is drepanocytes. Fine. Drepano is like a boat. They look like a boat, so I call it drepanocyte. There are many more findings here, right? Let's see other findings also. What cell do you think is this? Let's say this. I'm circling a few cells in black color. What cells are those? The circled one, what cells are those? They are smaller, they are darker, no central pallor. They are your classical spherocyte, right? Perfect. It's a spherocyte, right? Great. There are few more cells as well. What cell is this? I'll mark in red color. What do you think? What cells are these? These are my target cells, are podocytes, right? Right? I can appreciate target cells. I can appreciate sickle cell. I can appreciate spherocyte. One more finding. What cell do you think is this? I have put a red color arrow mark there. If you look at the cell, what have I marked now? Does it look red or it's having a bluish tinge? Is it completely red in color like other RBC, or it's having a bluish hue? It does have a bluish hue, right? So whenever there's a bluish hue, can I say it's not lymphocyte because I don't have a nucleus, right, Amrish? It's a bluish hue, which means there's some protein material or some DNA, RNA protein material is left behind. So that's an immature cell, that's a reticulocyte, right? Don't confuse them for lymphocyte. This is how a reticulocyte looks. The other name for reticulocyte is a polychromatophil. I'm going to name whatever based on whatever I'm going to look at, right? I call them polychromatophil. When I say polychromatophil, it's a cell. It's a mature cell, right? And it's more colors. I'm having the reddish color as well as I'm having slightly the bluish hint as well. That's a normal reticulocyte. A lymphocyte will have a nucleus. Maybe a lymphocyte will look like this. It'll have a condensed nucleus like this. then yes, I can call it a lymphocyte, fine. Otherwise, it's not a lymphocyte, it's just a polychromatophil, right? Got it. What cell is this? A black arrow mark. What cell is that? I want you to comment. Do comment. What cell is that? This is kind of a primary problem. We were able to identify sickle cell, we identified spherocyte, you did identify target cell, you also identify reticulocyte, which are all abnormal, right? The one which I have marked there is a completely normal RBC, right? We have to fill this gap. Somehow we have to fill the gap. Without knowing normal, I cannot understand and I cannot excel abnormality, right? So that's a normal RBC, that's a normal central pallor. It looks a little bit skewed, that's all. So just, there's also a normal central pallor. Maybe this a little bit more pallor, but still a normal RBC, right? So you should be able to pick up normal at any point of time in your life. Not only here, in patients. If you can say you are completely normal with confidence, you will be the best doctor. No one can say a person is completely normal without knowing all the abnormalities, fine? Okay, that's with this question, and I hope we have covered most of them related to that question. Okay, just to complete this, what is this finding? I'm sure you must have seen this finding before. You must have learnt about this finding as well. What is this? That's an H-shaped ring-like structure. We call this a caboring, right? Cabot or cabo, T is silent. It's caboring. Caboring, you see them in any place where I'm going to have a difficulty in nuclear maturation. See, caboring is a remnant of nuclear maturation. Can I say a megaloblastic anemia will have a defective nuclear maturation? Yes. Drugs, like cancer chemotherapy drugs, can it cause defect in nuclear maturation? It will. MDS, it will, right? It's nothing but defective nuclear maturation. If I remember this, I can remember everything else. I can have a megaloblastic anemia, which can have a defective nuclear maturation. I can have myelodysplastic syndrome, MDS, which can have it. I can have drugs, cancer chemotherapy drugs, which can have a defective nuclear maturation, fine? Okay, Amit, this is not a topic-wise thing. We are just having a 10 series of IBQ sessions. There's a third of them. First one was in the app, and the rest of them will be in the app as well, fine? So topic-wise, after finishing this 10, we'll still have 1 or 2 months time. We shall go topic-wise then on, okay? Okay, that's that one. We'll go to the next question. I want you to comment on the answer, read the question carefully, and then go with the answer. Great, been to a starter thing. Devi Priya, there is a video on Unacademy. Under my profile in special classes, there will be something called as Disease 360. In that, I have discussed in one of the videos about MDS. Right? If I can, I'll share the link of the Telegram chat. I'll share the link on Telegram with you. Fine. Any of this? Only 2 of them has gone with it. Okay, so what is your diagnosis here? The diagnosis here, I have a nesting pattern as my first clue here, and the tumor is excised, well demarcated, everything is fine. IHC shows synaptophysin chromogranule and scattered cells are SN positive. Those are my sustentacular cells, right? My diagnosis here is your pheochromocytoma paraganglioma, right? It's bradycardia and everything, so must be a paraganglioma, must be a carotid body mass, carotid body lesion, right? So here my diagnosis is paraganglioma. See, first I want you to know the diagnosis. Once I know the diagnosis, then I can easily differentiate. Now I'll kind of rephrase the question. Can I call paragangliomas as extra adrenal pheochromocytomas? Yeah, neuroendocrine tumor, obviously. Can I call them an extra adrenal pheochromocytomas? I can, right? Kind of. So generally pheochromocytoma, what is the feature to call it malignant? If I need to know one finding, okay, this finding, I call it malignant. What is the finding? It's metastasis, right? Only when it's a metastasis, I'm going to call it malignant, right? But here, unfortunately, I don't have that finding. I don't have metastasis here. For paraganglioma also same. When I see mets, I will call it malignant. I don't have my mets here. So if I'm not having mets, I'm going to take whatever Amit said, I'm going to call it a neuroendocrine tumor. If you remember neuroendocrine tumors of any place, there's a neuroendocrine tumor obviously. Is carcinoid also a neuroendocrine tumor? Carcinoid is also neuroendocrine tumor, right? In lung, you must have read this. Let's assume lung, when you have a neuroendocrine tumor, you must have read about carcinoid, atypical carcinoid, and small cell carcinoma, right? For all this variation of carcinoid, atypical carcinoid, small cell carcinoma, you must have put the entire diagnosis based on mitotic count. When I had a mitotic count of less than 2, I call them a typical carcinoid. 2 to 10, I call them an atypical carcinoid. Small cell carcinoma, I call it more than 10, right? So if I am not having metastasis, I am going to rely them on any neuroendocrine tumor on mitosis and the amount of necrosis. Pleomorphism is subjective. Some of you will say that this is also pleomorphic. I might say that it is not pleomorphic. So I want more of an objective finding. Mitotic count is a very, very objective finding. Mitotic activity will be a reliable finding for any neuroendocrine tumor to categorize them into benign, borderline or malignant, right? Keep this in mind. It's not only for paraganglioma. Pancreatic neuroendocrine tumor is available, same mitotic count. Any NET, I'm going to think of a mitotic count, right? In pheochromocytoma, like you guys said, metastasis is more important for me. But I do have a score. You need not remember this, right? Ignore this table. That's for me to diagnose. If I don't have metastasis, if the patient is saying that PET scan is not affordable, I should give a diagnostic thing, right? So if PET scan is not affordable and METs cannot be evaluated, I have a score called as pheochromocytoma of adrenal gland scale scoring system. Just remember the score. This score helps me to tell the malignant potential of a tumor of pheochromocytoma. Fine. So if I'm not able to identify the metastasis because of some problem, I'm going to use a PASS score to identify, say it's metastasis, it's malignant or benign lesion, right? This is not accurate. Metastasis is definitely accurate. Fine. Okay. Go to the next question. This question, if you know this, it's just a spotter. I just put this question just so that we'll understand that something like this exists. So take a wild guess, whatever comes to your mind. B and C. I'll answer your question, Amit. Anyone wants to take a call? It's fine, it's a new finding. B, a guess. Great. Sabhi, you're good with guesses. D, Imad has went for D. Okay, I'll answer Amit's question first. Pheochromocytomas are not ascendant positive. If you look at the question, what it was said is, I'll just go back to the previous question once and I'll come back to this for sure. If you look at the question, the question says that scattered cells are positive. If you remember pheochromocytoma histology, you must have found that there are cells in the corner called as supporting cells or sustentacular cells, right? Those cells are positive. Rest are completely negative. Rest tumor cells are synaptophysin chromogranin positive. Only the supporting cells are ascendant positive, fine? Okay, I'll come to our question. Okay, I'll tell this here. I'll give you a clue maybe. Of these 4 lesions, there is one lesion where everything will be big, like macroglossia, hemihypertrophy of the body, increase in size of liver, spleen, omphalocele. Everything becomes big. The orifices become big. Everything becomes big. Which lesion is that? Beckwith-Wiedemann syndrome, right? So Beckwith-Wiedemann syndrome, there is an inherent increase in size. That is also very well picturized in your adrenal cortex as well, fine? So when you look at the adrenal cortex here, I can easily say that the cells of the adrenal cortex are huge. In the background, this is my normal cell size. The tiny ones is the normal. This we call an adrenal cytomegally. Okay. I'll tell why this is useful again. Adrenal cytomegalomy is kind of diagnostic of Beckwith-Wiedemann syndrome. I don't see them in any other syndrome. I see them only in Beckwith-Wiedemann syndrome, right? It's not seen in any other thing. Again, why this becomes important is the problem comes with when it's economy. To identify Beckwith-Wiedemann syndrome, I need genetic diagnosis, which I can't do it. So when a person is not affordable for a genetic diagnosis, it's like a surrogate evidence to say that, okay, this patient has Beckwith-Wiedemann syndrome, right? This is just a very important clue for me for diagnosis. If it comes in future, it might help you. Adrenal cytomegaly, keep in mind, along with many organomegalies and the hemihypertrophy, put in adrenal cytomegaly as well. The cells will become bigger. Adrenal cytomegaly. It's megaly, right? Just a second. Everything is going to be bigger. It's adrenal cytomegaly. Sorry. Okay. The next question. It's a simple one. Look at the question, look at the options and come to an answer. 30 seconds as usual. Okay, guesses, answers. You're not able to see it, Amit? Are others able to see? Is it my network? Is that a problem, or it's yours in particular? Okay, I hope all of you are able to see the image and the question as well. Okay. Others are able to see? Okay, yours, fine. I hope others are able to see. Okay, if it's mine, I'll try to change it later on. I'll zoom a little bit if it's useful for you, Amit. Okay, upon histological examination of a tumor, the breast tumor shows large size cell, prominent eosinophilia, cytoplasmic, nucleoli, and apical snouts. And this is very, very important for me. I put this question particularly for this apical snouts, right? I'm going to draw this apical snout. Tell me what comes to your mind then, right? An apical snout is going to be like this. Let's assume there's a normal cell here. When I say apical snout, it becomes like this. It becomes protruding and the cell nucleus goes to the edge. What do we call this? You must have known this as one more finding. We call them an hobnail cell. Fine? Call them a hobnail cell. It's just protruding into the lumen, right? If you go to the image, it's the same thing. It's kind of going into the lumen. And if you can see, it's dissolving and secreting also, right? So this is the only finding required for me. Now you can easily answer the question. You must have remembered that you had a various type of classification of glands. Apocrine, merocrine and eccrine, right? You must have classified them. Which of them will have this finding? Which will go into the lumen and it will burst off? Which will have this finding? The hobnail appearance and the protruding one will be for every apocrine glands, right? Your sebaceous glands looks like this, right? It will be an apocrine gland, perfect. Your apocrine gland looks like that. So whenever I see a finding like this, I'm going to call it something related to apocrine, and every apocrine will be rich in mitochondria. Anything rich in mitochondria will have a completely pink color. Eosinophilia also is there. You can relate multiple places here. You must have read about a tumor called as an oncocyte. What will be the color of oncocytes? Renal oncocytoma, what will be the color? Completely pink in color, right? Because oncocyte is also rich in abundant mitochondria. Whenever mitochondria is more, it becomes pink in color, right? And this is an apocrine carcinoma. This appearance of hobnailing. Hobnailing is also seen in one more lesion. In clear cell carcinoma of ovary, I see hobnailing, fine. In ovarian clear cell carcinoma also, I will see hobnailing. Hobnailing is a finding seen in few other places as well. A normal type 2 pneumocyte, it's not a tumor. A completely normal type 2 pneumocyte will also have the hobnailing appearance. and most of the apocrine gland will have an hobnailing appearance only, right? Type 2 pneumocyte, clear cell carcinoma, everything will have an hobnailing appearance, fine. Okay, that's a learning point from this question. Okay, I'll ignore this. Go with this question. Let's see if you can pick it up. Again, I'll mute for 30 seconds. Look at the question. It's an easy one. Come to a conclusion. I hope it's an easy one, simple one. Don't answer by impulse. Read the question, look at the image, and then answer. If you want, I'll zoom the image as well. Again, don't go by impulse. Look at the image and then answer. There's a very easy diverting answer here. It's a trap. I don't want you to fall for the trap. Okay, let's discuss the question. I want everyone here to comment for the leading answers alone. Fine. Most of you here answered option B, right? The reason why you must have answered option B is I'm sure that you must have thought it's an pseudomembranous enterocolitis, and you must have answered option B, right? That must have been the reason for you to answer it option B, right? So when I take pseudomembranous enterocolitis, the pseudomembrane will be seen on the luminal aspect or on the serosal aspect. That's my first question. Just answer the leading questions, we can easily come to it. The pseudomembrane will be seen on the mucosal or in my serosal aspect. Pseudomembrane will be seen on the mucosal aspect, right? What do you think will be the color of the pseudomembrane? The color of pseudomembrane is nothing but pus. It will be yellowish, dirty color, right? The color of the pseudomembrane will be yellow and will be dirty appearance. It's just pus, and the destroying cells will be a whitish, yellowish, dirty appearance. Pus filled area, right? So here I am not having an yellowish color. Here it's the outer surface. I am not having lumen also. So it's an easy diverter. And I look at the intestine, antibiotic use comes, I go and mark it's a pseudomembrane. It's not. Now here what is the color here? You can easily pick it up here. I'm having black areas, right? Can I rephrase this and call this an intestinal gangrene? Will a gangrene look blacker? A gangrene will look black, right? It's nothing but an intestinal gangrene, right? It's just a gangrenous intestine which is looking black in color. When I have a blackish gangrenous intestine, now look at the options and tell me which of the 4 options will cause a gangrene. The only thing which can cause a gangrene here is hypotension. Maybe a systemic hypotension due to hemorrhage or fluid loss or blood loss, whatever it is. Whenever there is a hypotension, automatically what happens is it's going to go back to your the blood supply from the intestine will go back to my vital organs. So the amount of blood supply to the intestine will reduce, which will cause gangrene, right? So hypotension, because of the feedback, there will be less blood to the intestine. So there's less blood to my intestine. Obviously, there is a chance of gangrene. So that's a only far-fetched route here. So please don't go with an impulse. Don't write the answers immediately. That's one of the bigger problem for us. We tend to give an answer immediately and we might go wrong here. Fine. Okay. There's an easy trap. If you're falling for the trap, wait for 10 seconds. I always tell this to many of you. You must have heard this as well. Keep a 10-second rule. See, the reason for us is I want to write the answer immediately after the question is being displayed. The urgency or to be on the first is always there. Keep this in mind. Don't comment on any answer wherever platform it is within 10 seconds. Make it routine. When you wait for 10 seconds, you will read the question at least twice. You will have enough time to avoid your silly mistakes. When you have in the Unacademy app, if you have a poll, if you're not answering before 10 seconds, doesn't matter at all. Okay, the leaderboard of Unacademy app is not going to give you an answer. Yo, thing is bullseye. I write 25 on 25 in a 20 mark question. That's more than enough. After 10 seconds or at 68th second you mark the correct answer. That's also enough here. Fine. Okay. Mas Khan, you must have got the notice in your prospectus and in your hall ticket. Please go through them. Fine. Option should have been a severe hypertension. Yes, Abhimanyu accepted, but I'm not going to give you everything on the platter, right? It's always not the correct answer. It should be there. It's a choose the best option. Of the 4 options, the best option is going to be hypotension, or yes, like you said, severe hypotension. Fine. Okay. That's for today. Okay, Abhimanyu again. An hemorrhage from a peptic ulcer. Do you think it will cause hypotension or it will cause melena? Hemorrhage from peptic ulcer is very unlikely to cause a massive bleed and hematemesis, right? Unless there is a bigger artery being eroded, it will not cause that. Fine. So better option would be option C. That's all. Again, choose the best option. Best one here could be in hypotension, because when I say hypotension, I'm indirectly meaning that that's a severe lesion only. Because in a normal hemorrhagic shock, let's say a patient has a loss of 100 ml of fluid, hypotension will not come, right? Only when there's in 1 liter or 2 liter of loss of fluid, only then hypotension will set in. Whenever hypotension sets in, I'm going to kind of say that it's an irreversible stage of shock. I'm not able to compensate. Only when compensation fails, hypotension comes. So when I say hypotension, it implies that the patient is having a huge blood loss which is not able to be compensated. Fine. Okay. I hope it is clear. Right? Okay. Thank you for your time, and we will have few more sessions on the YouTube, as well as the rest of the sessions will be on the Unacademy app. You can download the app and you can follow me in the Unacademy app. My name is Ranjith. You can unlock any of my sessions using a code of PathoCups. If you already unlocked it, you can just come and join. Right? Thank you for your time. Okay. Thank you. See you soon. Bye bye.